Good morning all. And thank you all for coming. And I'd like to acknowledge the elders of this land and the elders of the place where I work, which is the Gadigal people of the Eora Nation, and Aboriginal people in this room, Torres Strait Islander or other Indigenous peoples in this room. So I'm a drug and alcohol physician, so I treat heroin problems, alcohol problems, pill problems, and I'm also a public health physician, and I do a bit of teaching and research on the side. I'm based at Royal Prince Alfred Hospital in Sydney. I won't name everyone on the slide, but the work I'm presenting reflects things I've learnt from a lot of people and work that other people have done as part of our teams. But I will mention two on the list. Bradley Freeburn has been a teacher of mine going back for some 15 years. He's a Bundjalung man and head of the Drug and Alcohol Unit of the Aboriginal Medical Service at Redfern. And Leanne Lawrence is the manager of the Drug and Alcohol Unit at the Illawarra Aboriginal Medical Service. So in this session, we'll just touch briefly on how we can make mainstream services work better for Aboriginal people. And I'll share a bit of the journey we've gone through, but also hopefully touch a little bit on, just a small amount on the research of what other services have found. I'll touch briefly on the importance of the Aboriginal and Torres Strait Islander workforce, and every year that goes by I become more and more aware of there are things that my Aboriginal colleagues can do that I just can't, and it doesn't matter how smart I am, how hard I work, that they have connections that I can never have. And then we'll just, and very briefly, I think it's preaching to the converted in an audience like this, but the unique role of the community-controlled health services, but also how community-controlled services can potentially do even more and expand their scope. So that's where I work, and our building's opposite that one. And you can see it's not exactly the sort of warm and cuddly spot where you go in and say, I think I've got a problem with alcohol. But nonetheless, we have a clinic across the road from that, and we have a lot of Aboriginal people come in. Probably 15% of our people coming for dosing for methadone or Suboxone are Aboriginal. We also get people coming for other reasons to our outpatients. We're very spoilt. We can admit people to the main hospital, and we can also pick up people from the main hospital who might come in with a broken leg but go into alcohol withdrawal. And then we have a regional detox at our neighbouring hospital and we all work at different spots. So sometimes I work at the detox, sometimes in the main hospital. And on a Monday these days, I work at the Aboriginal Medical Service at Redfern. And that's been a great learning experience for me and hopefully useful for them. So there's Brad at the back at the right. So a couple of years ago, he's got a little bit more silver in his whiskers. And I won't introduce everyone there, but I want to describe in this first bit the journey we went through trying to make our mainstream service a bit more responsive for Aboriginal people. Back in the mid-2000s, Kate Teasdale, who was the lady at the front on the left, led a process of consultation, and we talked to our clients in groups. We talked to the staff at the AMS, we talked to community, and we talked to our own staff about what we could do better. And we've published those results, and they're there, and I think the process itself was very useful, and we learnt a lot, and I believe we've come a long way since then. Some of the feedback we got from clients and from other spots is we need more Aboriginal staff, that people need to see friendly Aboriginal faces. And so very early on we employed an Aboriginal caseworker and a health project officer, and Peter Jack down the bottom right-hand corner is our current Aboriginal Health Project Officer. These days, we've gradually built on that. As of 2 weeks ago, we have an Aboriginal merit worker, and merit is our court diversion scheme. That's Marilyn. We have at our detox an Aboriginal nursing assistant. That's David. We'll show you him in a minute. And I've only put in brackets because we only had it for 6 months, but we actually had an Aboriginal doctor. We had Robin Shields as an Aboriginal doctor and psychiatry registrar, so she'll soon be a psychiatrist if all goes well. So, it's pretty exciting to have growing numbers of staff right up to the senior levels. I know it's still small and we want to keep improving on it. The women we consulted who are our clients liked the experience of coming together as Aboriginal women so much that they wanted us to set up a women's group, and that ran for 10 years. It's had a temporary lapse when the female worker we had left, but we're hoping to get that restarted soon, and we've also published a paper on that if you're curious on it. We've also tried to make our whole service more client-focused and more a one-shot stop. So we've now got a contraception clinic, we've got a Hep C clinic, all in our drug and alcohol outpatient walk-in clinic. We've got the connections officer who helps support people out of prison, comes and sits in our service a couple of mornings a week. And just this year, we've also got a lawyer 2 mornings a week. And that's been brilliant. So when people are having problem with debt or problem with housing, and in particular, problem with child protection agencies, we introduce them to the lawyer, and we introduce them. She wants to meet them early on in the pregnancy and help them get set up for what's the best way that they can get a strong case that their child won't be removed. And already she's helped us prevent one child removal. And just in this last week, the teamwork approach we've been able to have, because we have now the cross-links between the Aboriginal Medical Service, us, child protection, we have a specialist perinatal nurse, for drugs in pregnancy. We were able to, I believe, to prevent a child removal in this last week, and Peter Jack played a really key role in getting the young man engaged. He'd been trying to get onto treatment for 4 months for his heroin problem, and with us as a team, we were able to make it happen. The thing I'll just talk very briefly on too is the regional detox service. So we're part of the one local health district, and Concord Hospital is where our detox unit is. And they've been doing a lot of work. They used to have a system where if you wanted to go in and detox from alcohol or drugs, you had to ring at 8:30 every morning and say, I'm still keen, there's a bed coming up. So, it might be over a week or two you're having to ring every morning. And of course our clients, they don't have credit on their phone, they've got chaotic lives because they're still having to search for a hit or, go and search for a drink, and it's totally unrealistic. So they've thrown all that out. They've got a new medical director, new nursing director, and tried to make themselves as accessible as possible and keep every bed full with with clients turning over as to make the maximum use of the place. This is David that I mentioned, who's our Aboriginal assistant nurse, and he's doing on-the-job training to build up his qualifications, and that's a mural that a local, I couldn't get the name of the artist, apologies, did for the service. And I haven't got statistical tests on it, but just in the last 4 years, there's been a steady increase in the number of Aboriginal patients in the detox. And in fact, these last 2 weeks, 1 in 4 patients, they've got 21 patients, there's a 1-week detox, and people can sometimes stay on for an extra 3 weeks of stabilisation. And at present, 1 in 4 of the patients are Aboriginal, which we're very excited about. And the more Aboriginal clients you have, the more comfortable Aboriginal people are coming. And Peter also goes over there and supports them. So that's just the story of our journey at one hospital, but if you're interested, other people have written about their experience, and the research generally backs these principles. And I'm sure Aboriginal people in the audience, a lot of you in the audience are saying, well, it's common sense, you make it flexible, you meet the needs of the clients, but you sometimes need some evidence to try and get the funding, to try and beat people over the head, and to share the stories that we've all learned. And there's down the bottom just a few examples of the many papers that have shown these sorts of approaches: Aboriginal staffing, flexibility, better links with community, other sorts of things that work. So I'll talk briefly about community-controlled services, and if you're curious, that photo, it's Kangaroo Island down off South Australia. It's quite pretty. Community services, I think, are obviously immensely important, and an awful lot of clients won't go anywhere else, and very challenging times with government threats to funding of them. But we're going to talk about a particular problem, and that's access to alcohol and drug problems, and how community-controlled health services that are offering primary care services might be able to help. So this is a a guy based on a synthesis of a few guys. We'll call him Rob, and the court says Rob has to go to rehab or else he'll go to jail. You've heard this before? You've got to go to rehab or you go to jail. You've got to go to rehab or else your kids will be removed. But the rehab will only accept them once he's detoxed, once he's finished his alcohol withdrawal. But there's no detox beds available, and anyway, the nearest one's 1,000 kilometres away. So it's a really big problem. There's the lack of rehab beds, but then people can't detox to get into the rehab, and a lot of rehabs don't have detoxes attached. So sometimes the clients have to jump through so many hoops that, unless they're super determined and super mentally fit, they just give up and say it's all too hard. So here's where the Illawarra AMS came in, and this was a project that they initiated and we just got involved in to support them. So Illawarra AMS is, can I work that out? I don't know that works, but you see Sydney, and Illawarra is just south of Sydney. There it is. And there they are. And this is some of the team there, and just above me in that picture is Leanne Lawrence, who's the manager of the drug and alcohol unit. So they had been every now and then doing outpatient detox, home detox for alcohol problems, but they hadn't been able to get it up and going regularly, and the board of the AMS had quite a few concerns. Is this safe? Are we, we're giving people Valium. Are they going to end up getting hooked on Valium? And just for those of you who haven't worked in medicated detox units, Valium and benzos generally can be a huge source of problem in the community. So the board was very right to have concerns that this wasn't going to increase the problems. But in alcohol withdrawal, carefully controlled Valium can be life-saving because it can prevent the DTs, it can prevent seizures. And people who and by DTs I don't just mean the shakes, the DTs I mean people when they're seeing things and they're sweating and they're vomiting and they're diarrhoea and they're really sick. And if you've got full-blown DTs and you don't treat it with things like Valium or fluids or whatever, then up to 1 in 6 people can die from it. So they had been looking at what they could do, and they came to us, and we were able to get a bit of funding through the Foundation for Alcohol Research and Education, FAIR, to set up a pilot home detox program. They called it the A Clinic, beautiful art by Jasmine. And so for very carefully selected clients, you couldn't just do a home detox for everyone, like the sort of person who has seizures or the person who sees things when they have detox. They're actually not the ones you can do at home. They need a proper live-in detox unit. But if they've got a stable housing, if they don't get seizures when they stop drinking, and if they've got a bit of support, and if they're motivated and sensible and reasonably healthy, like not end-stage kidney disease, you can do a home detox on them, and we know that from experience of other services, Aboriginal and non-Aboriginal, and experiences around the world. So what they set up after a lot of consultation is they'd drive out to the person's home. Once the person was assessed to be suitable, they'd pick them up in the morning, bring them in each day during the alcohol withdrawal. They'd get quickly checked by a nurse. They'd be given their medications for the day, and they'd be dropped back. So they only get their Valium day by day, so there's much less risk of overdosing on it, much less risk of it getting out into the community, and all the Valium is finished within 7 days. And then in the beginning they were doing an afternoon visit for everyone as well, but some of the clients found that too much and it was very labour intensive, so for a lot of people that dropped back to a phone call if the client wanted it. And the whole time the person was getting support, while the caseworker was driving them in, they were getting informal counselling, and they said that time in the car was often the most precious time because everyone was relaxed, it was non-threatening, and people were talking freely. And we were planning for how they were going to stay dry afterwards, well, they, the team. And a lot of people were offered the relapse prevention medicines like naltrexone, which is just 1 tablet a day, and in research around the world it can probably double people's chance of staying dry. Not everyone accepted it. Not everyone probably needed it, but it was there on offer if they wanted it. And with his permission, here's one man's story. He was referred by a GP. He was drinking up to 20 standard drinks a day. So we weren't just talking about people, drinking 4 or 5 drinks. They had proper alcohol dependence. He was smoking 0.5 gram of pot a day as well. And he was Yandi. He is diabetic. He didn't have a phone. but he's, a sensible, motivated guy. He successfully did the home detox and has stayed dry since, and has become, had an increasingly positive involvement and contribution to the community. And of course proud of his achievements, rightly. We did focus groups with elders, with stakeholders and with clients and with staff. And the points that people liked about home detox was there's less stigma. It takes quite a bit of courage to book yourself into a detox unit or a rehab unit. You've got to put your hand up and say, I've got a big problem. Some of these people could just detox at home. No one else needed to know that they even had an alcohol problem. I mean, communities often know anyway, but they didn't have to advertise the fact it was out of control. They could just quietly get it fixed. It was much more convenient. They didn't have to move away from family and friends. Some people can, I've had people in Sydney with mild alcohol dependency who can even keep working while they're detoxing. But without the medicine, they were finding that they weren't sleeping, they were getting too anxious and they couldn't function. They had family around to support them, and I can almost hear you all thinking, but the family might pull them down too. Well, they had to screen, was it a safe house? And if their own house wasn't dry enough or supportive enough, then they could go to house of an auntie or house of a cousin, a spot where it was safe or dry. The other thing that focus groups said is, we trust the AMS. You need staff you trust to talk about this sort of sensitive business. And as we know, one stakeholder said a lot wouldn't go to a mainstream service, they would only go to the Indigenous one. They also were, there weren't long waiting lists. If they were seen during the week, they could generally be started on the Monday of the following week. This particular client says, so I had an appointment in the morning and at lunchtime I was at the AMS and I was on the program. You don't have to worry about the details, but in summary, we're not talking big numbers. We had 20 that were assessed. A lot of them were ruled out as not being suitable because they had seizures or they had a pill problem or whatever. Only 8 were suitable. All 8 completed a home detox suitably. At least one of them took it the second time till they got there, but all 8 did, most of them the first time. And at 6 weeks follow-up, 7 of the 8 were still dry. To our knowledge, 1 was lost to follow-up, and we'll assume that they're probably still drinking. So in wrapping up, we can keep improving, whether we're a mainstream service or Aboriginal community controlled or anything else, we can always keep improving. It's just like us all through life, we hope we keep learning. And in a mainstream, I think it's really important we step back regularly and say, who's not coming? It's all very well looking at who's walking through the door, but who isn't coming? Are we seeing as many people as we should be seeing? And why aren't clients staying? It's all very well to say, they're not motivated enough, but what can we do that makes it more likely that clients will be happy to stay? If it's a rehab service, for example, or a detox. And for community controlled, I think the sort of questions people can ask, can we pick up problems earlier? There's a tendency to wait till a person comes and says, I'm ready, I've got a problem, I need help. But we know in mainstream and in Aboriginal, if you wait till then, the problems are advanced and they're severe. And it's much, much easier for people to change their drinking if you can pick it up a bit earlier. And hence all the emphasis on screening, whether it's through IRIS or Audit C, but a couple of quick questions that everyone gets asked in their adult health check or maybe when they come for a visit. And also detoxes can look at, can we offer community-controlled primary healthcare services like Aboriginal medical services, can we offer the full range of treatment? Things like home detox, once you've got the hang of it, it's actually not that hard to do as long as you pick your client carefully. And I've done at least one through the AMS Redfern now, and he was a bloke who'd been drinking since the age of 13. The first drink he ever had was metho, and he's now been dry for about 4 months. And he was a particularly sensible guy, but it can be done, and once you've got the hang of it, it's not hard. Things like the relapse prevention medicines, they're not a magic bullet, but they can help a little bit for some people, and they're worth considering. So there are a lot of things that can be done. I think partnerships are key. We can all learn from each other, and in particular partnerships between mainstream and community controlled, and partnerships between non-Indigenous staff and Aboriginal staff. I think as a non-Indigenous staff member, we have to really be mindful of the pressures on our Aboriginal staff. We have to offer them support, ongoing training, but we also have to be mindful of how much they can teach us. And I think the Aboriginal and Torres Strait Islander workforce play a really special role. Thank you.